Okay. So, well, this we're talking about tendons, and here we can see the profunda coming down here, the superficialis profunda going through the superficialis, like we talked about before, and the lateral side there's a superficialis attachments there. We can see a little fluid deep to the tendon. This patient had pain here, and on the coronal stir images, you can see that there's a lot of fluid surrounding the flexor tendon here, and then this linear signal intensity going along the course of the tendon. If we go to the cross-sectional images, you can see increased signal intensity here in the profunda. And if we followed it, you can see that increased signal intensity all along the profunda. And this is a split tear of the profunda with some tenosynovitis surrounding it due to the irritation of the tear. So that's a longitudinal profunda split tear. Okay, Robert.
All right. So here, looking at the volar aspect of that second metacarpal, looks like there's a complete tear of the tendon. It looks like it's both tendons, at least in this plane, or the profunda at least.
And if we go to the coronal images, you can actually see the retracted end of the profunda tendon here.
No, that's no man's land. That's not fixable right off the bat.
Okay.
You have to wait and before you fix this one.
And then go to the axial images, we can see a little bit of increased signal intensity in the profunda, fluid replacing the profunda in the area of the tear. Again, fluid replacing the profunda. And then now we're coming back to seeing the profunda. So that's a full thickness retracted tear of the profunda.
This looks just like the one my ex-chief threw the patient out of the hospital for.
Oh my God.
He blamed the patient, not himself.
All right. 53-year-old male injured in a fall cannot bend the fourth digit.
There's one image. We can see where this digit is, that the symptoms are.
Yeah.
And here's the next image.
Okay, look like I don't see any profunda tendon there.
Okay. Here we can see empty. There's a superficialis, but
yeah,
no profunda. Now we're seeing the profunda again as we come down. And then here we can see the full thickness retracted tear of the profunda.
There's another one.
Okay.
42-year-old male, post-op pain. Looking at
there's a third digit that hurts in the palm of the hand.
there is signal running along the flexor tendon. Could be a partial
bit of fluid next to it there. Now, if we go to the axial images,
we're looking at the superficial tendon has some signal in it, but
yeah, and we got a lot of thickening overlying it compared to the normal side. These are kind of the normal, getting close to the pulleys over there. This is markedly thickened and irregular. And we can see that this was a split tear of the superficialis. So you have to be careful about that with the superficialis because you know it normally splits. So you have to be a little bit more careful. Robert.
All right, so we have a 53-year-old physician with RA and unable to flex a thumb. And there's a discontinuity of that FPL tendon.
That can be sutured.
Okay, Robert, you're back. John.
All right. So we have a 53-year-old physician with RA unable to flex a thumb. And it looks like there's a full thickness tear of that FPL that's retracted and a lot of edema there.
Okay. All along there. And there you see it. There you don't.
Yep.
Should be right in here. And there we see it again. Yeah, so that was a full thickness flexor tear. Tayson?
All right, looks like the flexor tendon is torn at the level of the IP joint of the thumb, right?
Okay.
Yeah.
So how do you think this happened?
Yeah, laceration. So you see the soft tissue laceration there as well.
There it is, right. So there's a laceration. So one of the problems in emergency rooms, and maybe you guys, if you've ever worked in the emergency room, remember this, is you never wanted to suture a laceration unless you're certain that you didn't have a laceration of an underlying important structure. And I've seen several now that have where they've sutured the skin lesion, but didn't diagnose the underlying tear, and they had to go back in and reopen it and work on the tendon.
As long as they didn't wait too long.
Yeah.
Sure. So flexion difficulties after a knife fight, we see a tear and retraction of that deep flexor tendon.
Not fixable.
Okay. Robert.
So we have a 17-year-old female cut on hand 1 month ago. Evaluate for injuries to the second and third MCP joints. Looking at the flexor tendons of the second digit, it looks like there's a split there. Yeah. Yeah, and right there it looks like it's completely torn and retracted. Yep.
And there it is again. And then here you can see the tear, and then there's proximal retraction of the proximal fragment due to laceration. Okay. Tayson.
So, top image looks like the superficialis is torn. Probably
Yeah,
the
so
profunda as
here we
well.
can see that looks like there are tears in through here, and we see a lot of scar tissue.
Yeah.
And through here, and this was a chronic tear that had been there for over a year, and these are very difficult to treat. So, John, you were saying something about how you need to treat these right away, right?
Yes. You don't want to wait more than a week.
Okay.
They should be done as soon as possible.
Thanks.
And you can start motion as soon as possible also.
Great.
Gently.
So in the region of the flexor tendon, I'm not seeing normal tendon fibers. There's soft tissue, thickening.
Yeah.
Could be synovitis and tenosynovitis.
Right. Yeah, exactly. This is flexor tenosynovitis. This was a patient that we'll talk more about next week who had psoriatic arthritis, and this was a sausage digit from psoriatic arthritis. Okay, Robert?
All right, here looking at the third digit flexor tendon. Looks like there's a lot of fluid surrounding the flexor tendons. I'd be concerned about tenosynovitis again.
Right. And there we can see it. And if we go to the sagittal images, you can see a lot of the fluid tracking all the way along the flexor tendon and then along the flexor tendon sheath. So very typical of tenosynovitis. And a lot of tendinopathy within the tendon here as well. But the tendon, if you carefully look at it, is intact. And this is flexor tenosynovitis. And I don't remember what the underlying cause of this was. You have to think about infectious disease, think about psoriatic arthritis, and then think about the other kind of arthritides. But you certainly have to think of infection first.
Even trauma.
And trauma, right, John? Thank you. So if you get a partial tear, you can get hemorrhage into the sheath and develop tenosynovitis from the blood. Good. Okay.
All right. 65-year-old female with volar mass. It's in the region of the third metacarpal head. We see all this, I guess, heterotopic ossification.
Yeah. And here are the axial images.
Yeah.
Here are the sagittal images.
Looks like it's superficial to the flexor tendons, right?
All the way along here.
Yeah.
And this is calcific tendonitis involving the flexor tendon. We will talk when we get to the inflammatory section about some diseases that predispose to calcific tendinopathy in the next section. I don't remember exactly what the underlying etiology of this was. Certainly, if you have prior hemorrhagic tenosynovitis, you can get calcium deposits like this, possibly in psoriatic arthritis, but I don't remember seeing calcific deposits like this in psoriatic arthritis. You certainly can think about gout, and then there are a lot of the chronic dermatitises that can produce calcification. Usually, that's a little bit more diffuse and not just along one tendon sheath.
A pretty unusual case.
Yeah.
Okay, so marker volar aspect to that second digit. See some mild tenosynovitis.
Yeah,
Surrounding the
you
flexor.
can see kind of odd, let's see, kind of increased fibrous tissue in between the tendons here as opposed to over here. If we go to the sagittal images, this is fat suppressed. It'd be good to compare it to a non-fat suppressed to look at the fat here, and this would all kind of be irregular going along the course of the tendon there with focal areas of fluid collection. This patient couldn't fully extend the digit, and actually mostly the fourth, but also, this is probably the second, third. So it was mostly the third, but I think the second and fourth are a little bit involved as well. Do you have any ideas of what this might be?
Maybe the Depuytren contractures.
So this was Depuytren's contractures, right? Okay. We'll talk more about that in the inflammatory section as well.
It looks like the phalanx is bent. I don't know if I'm.
It's chronic disease. Maybe it has remodeled. I'm not aware of noticing that, but you're right. It does look like it might be a little
pretty rare area also.
Yeah. Yeah. Okay. And then here we can just remember if you have pain in a digit, also you need to remember you can get traumatic injuries to the bone. Here's a little buccal fracture of the cortex. Don't forget you can have fractures too that can sometimes masquerade as tendinopathy. So why don't we stop here, and then we'll start up a new section on Monday. Any questions?
Nope.
Thanks, everyone. Have a good weekend.
Thank you.
Have a good weekend, everybody.
Thank you. Thank you.